Hi, welcome to our introductory podcast. This is our new podcast. It's called Unraveled, Understanding Complex Illness with myself and Dr. David Kaufman. So today's initial episode is really just an introduction of who we are and the origins of why we decided to offer this podcast. And I think that all of the listeners will really enjoy hearing Dr. Kaufman and I'm just going to call you David.
That's good because I'm going to say Ilene.
David and I just sort of pontificate and analyze and discuss different diagnoses, different symptoms, different patient cases. We often come up with things that are really interesting and we think that others should hear it or others should listen in and eavesdrop. But introductions first. So my name is Ilene Ruhoy. I am a neurologist. I have a PhD in environmental toxicology. I also did a fellowship in integrative medicine. So I like to think that I bring to my practice different perspectives, not only neurology, but environmental toxicology. I've always believed that our environment contributes to making us sick, as well as sort of an integrative approach. So I see things through a different lens, and I'm often willing to try and experiment with certain kinds of integrative approaches to help patients heal. And that very much fits in with sort of the chronic and complex world, who rarely, if ever, respond to one or even two or even three medications. And so it often takes a lot of combination of different modalities to try to sort of move the needle for them so that they improve and they feel a little bit better. Over the years, I've had my own health challenges and actually had an experience where I wasn't believed for some of the symptoms that I was presenting with, despite the fact that I was a neurologist and was actually seeing colleagues. And so I knew what it was like not to be believed. And it was because my exam was normal and my labs were normal. And I knew something was wrong because I knew my body better than anyone else did. And I realized so do my patients. And so that sort of was a turning point for me in my career in general, where I recognized that, no one else knows their body better than they do. So I always start from believing the patient because I have no reason not to. And I go from there. And so over the years, I've really developed a practice of just seeing patients who have been suffering with a lot of chronic illnesses. Some have names, some don't. And that's one of the things that we're going to be talking about. We have lots of topics. And so I'm real happy to actually join my colleague and very good friend, David Kaufman, who I really enjoyed working with and really enjoyed meeting for the first time just a couple of years ago, actually, when we were in Denver at an MCAS meeting. And we'll talk about our MCAS group as well. But and ever since then, we've had a really, I would say, collaborative and fruitful partnership for sure. And I'm just excited to be doing this podcast series with him.
Okay, it's going to be a tough act to follow. So my name is David Kaufman. Two disclaimers to start with. I have my first cold in 3.5 years, so I sound a little sputtery and hoarse. And second, I'm very nervous. I've never done this before. This is an idea that Ilene and I have tossed around for the last at least a year. Comes out of she and I meeting every couple of weeks for 2 hours or so and just kind of talking about patients and medicine and healthcare and complex illness and realizing that we have a lot we want to share. So we've been looking forward to doing this. So I have been a physician in New York for 35 years doing internal medicine and HIV medicine. Started out in 1980 just as the epidemic started in Greenwich Village. So it was kind of on the frontier edge of that whole thing. And I think aside from many, many other things, it taught me to listen really hard and look for ways to treat patients, even if they were not yet proven, because as you probably know, it was a desperate, desperate time. And excuse me, that experience is translated very well, has given me significant benefit in terms of taking care of patients with complex illness. And over the last 10 years, that's what I've been doing here in the West Coast. And it's been incredibly educational, exciting for me. Plus, been meeting other physicians, which has been quite amazing. I mean, meeting Ilene at that conference kind of got this whole thing going. And now we're part of a listserv with about 350 other clinicians, which has been an enormous benefit to teaching and learning discussing quickly actionable treatments for patients, and just sharing both frustration and knowledge. So I look forward to doing this. This is a work in progress for both of us, and we will be asking you for your help in terms of questions and discussion topics and suggestions and criticism, and much more. Thanks.
Yeah, along those lines, we do have an email address that if you want to submit questions or topics that you want us to take on and tackle and discuss, it's unravelingcomplexillness@gmail.com. I spelled unraveling with 2 L's. So because there are 2 different spellings. And I know that the title of this podcast is Unraveled with 1 L. So just to be clear, it's unravelingcomplexillness@gmail.com, unraveling with 2 L's. And so feel free to send us ideas and topics and any thoughts that you have or things that you want to hear us sort of just discuss and chat about. We're happy to do so. We welcome and are very receptive to different ideas. And the one thing about that MCAS group, I'll never forget that first meeting that I went to, that is where I met you. It really is liberating to find out that there are other physicians that are seeing what we're seeing, doing what we're doing, thinking what we're thinking. Because for a while there, I sort of felt like I was on a little island by myself.
Right.
So I think it's nice. And we're also part of some other clinician groups, none necessarily as big as that one, but some other clinician committees that are working on these more chronic and complex illnesses. And it really is exciting to me when someone posts in the group and then there's more information and someone learns something from a patient case. And I always say that, and I think that you agree. I learn more from patients than I ever did in medical school, than I ever did in residency, than I ever did in fellowship.
That is so true.
It is absolutely. I mean, it's amazing the things that you can learn when you just see patients on a regular basis that are suffering with a lot of these very controversial, right, and complex illnesses.
Yeah, no, that's so true. I think I learn every day. One of the beauties of the internet is that patients can search as well, and they send me papers, or they bring papers, they send me links, and it's great. I mean, I spend a lot of time reading, but I can't cover the entire Google world, so it's incredibly valuable. So it's right up there with listening to the patients when they describe their problems, in the value that they bring in terms of further knowledge. So it's great.
Why do you think that not all physicians seem to receive links from patients in a kind manner? They feel sort of off-put, I think, when patients share what they find on Google. Why is that? What's your opinion on that?
You're opening up a big can of worms here, Ilene. I think there's a couple of reasons, many reasons. One is just the healthcare system in general. The insurance-based healthcare system pretty much mandates a 10 to 15-minute visit if the patient and the physician are lucky. That doesn't leave a lot of time for the extras of, oh, look at this article I found, or have you ever considered this? I have a friend who took this medicine. They don't have time to discuss that. Secondly, even though it's 2022, medicine is still pretty paternalistic. Mm-hmm. And, I'm the doctor, you're the patient, so what are you telling me this for? So it's sad because, as we both have been saying, we just learned so much from the patients.
Yeah, no, for sure. Yeah, I definitely do.
And I want to emphasize what you said before about the mast cell meeting and this group on the listserv. It is an amazing experience to be able to work with people, talk to people who think outside the box comfortably and are ready to share things, recognizing they may not be as much proof as we would like. It makes a huge difference in patient care and in our own, or certainly in my confidence in what I'm doing.
I completely agree. I mean, I always think that, evidence-based obviously is very important for lots of reasons, and we both appreciate that and recognize that as physician scientists for sure, but not everything can be evidence-based, at least not at the moment in time that you're trying to help a patient. But I always say that there are, at least the things that I try are theoretically sound, for sure, just based on my own training, education, knowledge, experience. And some of it is anecdotal, things that I've seen work for other patients I think are perfect. Of course, everything we try is generally safe. And I always feel like, well, it worked for this number of patients. Let's try it on you. And so, but not everything is evidence-based. And I think that that's okay. And I think there needs to be a little bit more flexibility in terms of what treatments are recommended based on how much evidence there is.
Right. Yeah. If there is a suitable, appropriate guideline and a suitable evidence-based action, wonderful. But I think, as we all know, dealing with these complex, chronically ill patients, there's very few guidelines that are applicable and very few evidence-based clinical trials. So what does that mean? We're not supposed to take care of the patients? Obviously,
Exactly.
that's not true.
That's what I always say.
Right.
Like,
So,
what am I supposed to do? Just
right.
ignore the patient just because there isn't a randomized control trial about
Right,
this?
exactly. So
Yeah.
for doctors like us, I think the guidelines in evidence-based medicine are restraints, and we need to be comfortable going past those restraints and making our decisions based on what we know, and on, as always in medicine, a careful calculation of risk and benefit regarding the intervention.
Yeah. I do take a lot of time when I'm recommending a certain regimen. I take a lot of time to explain to the patient why I think this might help, like what my theory is about it, what I've seen before, what I've read about it. And I think I'm clear, and I hope and I always ask the patient, do you understand why we're trying this? Because it may not be where they could just sort of look up the med and see, oh, it is used for this indication. They might find that it's used for another indication. And I'll often say, if you Google this, you might find that its primary indication is for this. You don't have this, but here's why it works for this. And here's why I think it'll work for you.
Yeah,
I often say that.
Yeah, that's a very important point. And I will often do the same thing. I know you're going to go home and Google this, so let me tell you right now, this is an off-label use for this medication.
Right.
This is why I'm suggesting it. These are the risks. And I'll often even give them or send them links to papers to support that decision. And I've even taken paste and copy from our listserv when somebody's discussed it, so I can show them where this idea is coming from. And I think it makes a huge difference.
Oh, huge. And I think patients really appreciate it. Yeah. And I also tell them that, when they look up their own symptoms or their diagnosis on the internet, I always say that the internet has like the best of everything and the worst of everything, but 95% of what we see in medicine is somewhere in between. And you don't pick up that nuance, I think, on the internet, which I think is sometimes the problem when people are Googling a lot of their diseases, their diagnoses or symptoms. And I think it doesn't really give them the full breadth of what we know really happens in medicine. And, we don't really know anything is really sort of what the more you practice, the more you realize.
Yeah, I was going to say each day I feel like I know less, not more. That's absolutely true.
I know. And it's funny because we learn more each day, right? But yet we feel like we know less. And it's just...
I think each time, this is generalization, but each time I learn something or we learn something, we realize that opens up a new avenue, a new rabbit hole that I don't know enough about.
Oh my God. That is so true. That is so true. And sometimes I feel like I wish I had trained in every specialty, right? Like I wish I were also a hematologist and also an oncologist and a rheumatologist and immunologist, a gastroenterologist, a cardiologist,
Well,
what did I forget? Oh, no. Pulmonologist.
So that's a good point, because in the work we do with the kinds of complex, chronic, really sick patients we take care of, I have had to try to become an endocrinologist, an immunologist, a hematologist. And I know that may sound arrogant or presumptuous, but I can't get the consultative help I need.
No,
so
I agree.
I spend hours on the internet reading and learning and looking at things that I never learned before. And the truth is that's exactly what I did in 1980 with HIV, when we didn't know anything. It's exactly what my HIV group did right through till the mid-90s until we had good drugs. So it's the same kind of process.
I'm just so impressed by that parallel you have of your HIV experience, because you were sort of on the forefront in the early days before we knew anything.
Very early days.
But that was good training ground, right?
To take on
these patients that you've been doing now for really way longer than I have been. Yeah. But, I think that was a really good experience for you, that I'm actually first sort of learning how to navigate a lot of, as you say, a lot of other specialties are brought in to these patients. And I call myself an amateur, like labeled a specialist, but I do that work for the patients because I do send them sometimes for a referral, but oftentimes I don't get, enough information back to really help sort of, draw the line between the two dots that I'm trying to connect. So then I sort of have to do the work myself. But it makes me feel better to at least have had a true specialist weigh in, that there isn't something more ominous happening just based on a couple of labs that I had seen. That gives me at least a little bit of leeway to feel like I can go forward with trying to sort out how it relates to what I'm trying to treat and to what I'm seeing. So I sort of like that aspect of it.
Yeah. At the risk of saying something controversial, it's been a very frustrating experience referring patients to the academic medical centers for consultation, it's 9 times out of 10, it's an unhelpful process for the patient, enormously frustrating for me. And again, one of the great things about our listserv, the MCAS listserv and the MUCFS collaborative group, is there are subspecialists in those groups.
Absolutely.
On the MCAS group, we have everything.
Right.
Literally everything. I don't think we're missing any subspecialists. And all of these people on the listserv, because they're interested in the same thing, they have open minds, they're ready to jump out outside the box, and that's been huge.
I agree. And I think patients get the benefit of all that, right? So it's like they not only see us, but they're also getting the benefit of this entire group of physicians that we're part of and that we learn from on a regular basis. And because it's a very active listserv, and that's what's great about it. And people are so willing to offer up not only their own expertise, but even their own experience with some complex patients. And I find that really, really valuable, really valuable.
So why don't we move into sort of an informal discussion of the kinds of illnesses, pathologies, et cetera, that we're going to focus on going forward. And again, always asking people to send in other suggestions if
absolutely.
we're not covering it.
Well, we gave our talk on the septad at the ILADS meeting.
Right.
So those diagnoses.
Right. So clearly we see patients who fit the criteria, the label for ME/CFS. I think both of us pursue a road where we use that as a diagnosis or a label, but we look underneath it because that's what we think is really going on. So that's where this concept of septad comes from. And that includes mast cell activation syndrome, autoimmunity, gastroparesis, and small intestine bacterial overgrowth. I always start losing them all. Chronic infection, hypermobility EDS, cranial cervical instability,
tethered cord, Eagle syndrome, median arcuate ligament syndrome. All connected tissue is a big topic, and I've taken it on over at the Chiari EDS Center, and connective tissue is everywhere, so it can manifest in so many different ways. So each one of those kinds of disorders, dysfunction, we'll tackle at some point along the way. So many things interconnect that I think one of the challenges will be, of course, just focusing on one diagnosis.
Yeah, I was just going to say that I want to caution people listening or watching, and I'm going to caution myself and colleagues and patients all the time. If I say mast cell activation syndrome, that doesn't mean you don't have SIBO and there's no interaction, or no interaction between your connective tissue disorder and your autoimmunity. These things are all interactive, bidirectional, and it is a fundamental concept that we have to understand and explain to our patients.
Absolutely.
So that we can all move forward. It's so critical.
Right. So many things are interconnected that it's going to be hard to stay focused, but we'll try to, as best as we can, just so we can cover the topic and I guess in more depth. But, beyond that, we'll go into a lot of the, even the smaller topics that also play a role in the disease, the different diseases, because even like certain nutritional deficiencies and what they can do, certain neuropathies and how they present. I mean, even the peripheral nerves are covered with connective tissue. The muscle fibers are covered with connective tissue. So, connective tissue just sort of has its tendrils everywhere.
Right.
And speaking of, so I always say that I think with a lot of, especially with hypermobile patients, there's an anatomical diagnosis and then there's several non-anatomical diagnoses. And I think it's important to identify and address both, because both can be playing a role. And we've often said this to each other about patients that we collaborate on. I mean, no medication or supplement in the world is going to correct an anatomical problem. Right. So we've many times have said that, but it's important to address the non-anatomical problems. So it's like all that, the MCAS issues for sure, the chemical sensitivities, the mold exposure, the other environmental exposures and what they can do. We're going to talk about mitochondria and how they play a role, nerves, muscles, gut, lungs, heart. I mean, all this, our organ systems, all the nutritional deficiencies that we see, the neuroendocrine axis and how that goes awry and how that can play a role. Even just some of the foundations of health, like how nutrition plays a role, how sleep plays a role, how movement plays a role, how stress management plays a role. We're going to talk about healthcare at large and all the problems within.
The system.
The system.
And the
systemic problems.
And I think one of the reasons Ilene and I work so well together and have so much fun talking together is we bring our own strengths, obviously, to this stuff. So, I mean, Ilene, you have this amazing training experience in obviously neurology, but also EDS and mitochondrial disorders and environmental toxicology. I bring my chronic infection, my HIV infection experience is a huge bias of mine. I don't know if bias is the right word, but what I mean by that is that I will always look for infection. As far as I'm concerned, infection is almost always there, needs to be searched for relentlessly.
Well, research is proving you right.
I think so.
I mean, now we know MS, Alzheimer's,
Exactly.
and some of the well-known neurological diseases that we're now finding it's got viral components to it.
I posted an article today on Masterminds discussing how intracellular bacteria can hijack the cell, hide from the immune system. I mean, these are things we know, but they were discussing a whole new discovery related to intracellular Golgi apparatus. And it was like, there it is. Again, it's right there.
Yep.
You know?
Yeah, and I will say that is why I love collaborating with you, because I know little to nothing about infection. Other than the bare basics, that you learn, that every doctor knows. But you really have a depth of knowledge that is so impressive. And so I love collaborating with you because you really know where to take it in terms of even testing for infections.
Right.
Like, I mean, if it wasn't for you, I wouldn't know half the tests that I order on some patients. So I think that's why it's such a good collaboration.
So another goal that we have is to get more physicians interested in this work.
Yes.
I was going to say recruit physicians, but that's probably too bold. So I'm hoping we get some physician viewers or listeners and excite them by this. I mean, as an older physician, the opportunity to do this work has been like starting my career all over. Mm-hmm. It's an amazing experience. And I think there's a lot of physicians out there who are frustrated by the healthcare system, frustrated by their lack of ability to help a significant portion of their patients. It's easy to treat hypertension. It's easy to treat a strep throat, but most of them kind of like get pretty uncomfortable when the patient comes in and says, I have trouble concentrating and I'm very tired. Mm-hmm. And they can learn that there's much to be done. And along those lines, I'll point out one other thing. I came to the West Coast 10 or 12 years ago after working in New York. And I was a very busy physician seeing lots of patients with very complicated, usually fatal diseases. I never knew anything about mast cell activation syndrome. I never knew anything about SIBO. I knew about POTS, but I didn't really take care of it. I didn't know anything about hypermobility EDS. Mm-hmm. Craniocervical instability, I probably couldn't have even said those words back in New York. So my point being, I've learned all this stuff new, and it's incredibly exciting. And I think it's something other physicians could really...
Because it makes a difference. I mean,
it makes a huge difference.
When you identify it and treat it, it really does make a difference to patients. And I have the same story. I think back now, I often talk to Stephen, my husband, about this. I think back on patients that I had seen when I was working in the hospital, and I wish I remembered all their names, because I would call them and I would say, I know what's going on with you now.
Yeah.
I wish I knew then what I know now.
Right. Right.
Just from what I've learned from you and all the other docs on our mast cell listserv, but also on some of the other committees that we're on, because I now know what was going on with these patients, and I could have helped them better. And I don't know if like regret is the right word, because I did the best I could at the time, but I just wish I can go back in time and take my knowledge with me. And I think it's important that other physicians sort of also become more aware of these diagnoses, right. and it could potentially change their treatment of patients, and certainly change how their patients respond to treatments.
Yeah. I hope that that's one of the things that happens with this podcast.
I hope so too.
This video.
Yeah, absolutely. I'm excited about it. I think we're going to do a lot of good stuff here in this podcast.
Yeah. So, in terms of learning these new things and seeing these patients, I'm not sure how this segues into what you just said, but
everything segues.
Okay.
That's our goal.
So
we have no segues.
I assume you feel the same way. There are moments when I think, wait a minute, I must be making this up. This can't be.
Oh, yeah.
It doesn't make sense, or it's too. There's not enough written about it. How come I be doing this? So, so as an example, I'll have a patient who I think first meeting and I've sometimes done this even before I had my first appointment. I'll say, geez, sounds like mast cell activation syndrome. Until I see you, why don't you just buy some over-the-counter antihistamines and an over-the-counter heartburn drug, Pepsid, and let me know how you do. And I now, even after 10 or 12 years, I am astounded when I get that email that says, I'm like 50% better from these 2 stupid pills for $2.
Right.
And it's just, I'm still amazed by that.
It can be so easy.
Yeah.
But, speaking of mast cells, I mean, one of the things that I hope we tackle is that sometimes it's not just the histamine, right? So there's all these other mediators that play a role.
Yeah.
And so, patients often think that antihistamines should cure them.
Right.
And while they often help, I think that there's a lot more to talk about the mast cells and how they're, involved in some of the other kinds of presentations we see.
Right. And what kicks them off.
Right? That's the big trigger. What's, part of the innate immune system. So what's the provocation there? Right. Why is the adaptive immune system now playing a role? Because then as you mentioned, the autoimmunity that's involved.
Right.
And I mean,
we all have mast cells.
That's true. Right? They're everywhere.
We all have mast cells.
And we all
Why
have,
are mine okay
and we all have
not?
we all have histamine receptors. And I always say, the H3s are in the brain. We talk about H1, H2 because all those over-the-counter ones, H1s, H2. Let's talk about H3s for a little while, know. So I think there's a lot to sort of cover, even just with the mast cell activation disorder diagnosis. Like that alone is like a couple of podcasts.
Multiple shows.
One thing we are looking for is a logo.
Oh, good.
Yeah. So we're not graphic designers. I'm not even artistic. Are you artistic at all?
No.
Maybe you take really good photos. Actually,
Thank you.
But we're receptive to logo ideas, and we're looking for help.
Yeah. So send them to the email. Which
send them to the email.
Unraveled with 2 L's.
No, unraveling complex illness at gmail.com. Maybe we could put it up on the screen. And so just I'm still manning the email for now, unless you want to join in. So if I don't get back to you right away, it's probably because I was overwhelmed.
I'll be nice and short.
Okay.
You just have to give me the login.
I'll give you the login.
Password.
We're open to logo ideas because we want to get a logo up and going. And we plan on dropping 2, that's the word, right? Dropping the shows. We plan on dropping 2 a month is our current goal. Obviously, everything is up for negotiation and for change.
Length of show may vary also.
Length of show may definitely vary. Depending upon the topic. Oh, and we also, so this is not a typical format, right? We're not going to be inviting guests every time, but we will be having other providers and guests join our conversation, as we like to say. They'll be just joining our conversation as opposed to like an interview style kind of guest podcast.
Right. Yeah, I think that'll be good. And it won't be every show, as you say, but I think when we get people, it will be really, really good.
Yeah. Because we know some good people.
Yeah, I mean, I can just picture putting a 3rd or 4th person in here. We could go for 2 hours.
Oh, easily. Easily. Absolutely.
Yeah.
So that's sort of how we envision this. And we're both real excited about it.
Yeah. So send us your ideas, your questions. If there's a topic you want to discuss, we will try. I think we're going to try to do show notes.
Yes. Yes, we are.
It's just the 2 of us, so I don't want to promise too much. But I think we'll try to put, links to papers and, references. And
I think, and one idea for some shows maybe is that we take on some articles, for example, almost like a journal club.
Right.
Remember the journal club days?
Right.
And we can sort of discuss what this maybe 2 articles that are on the same topic kind of thing. And we can discuss what they show. Right. And even, if it's a true journal club, then we go through the methodology and whether this really holds water or not and why we think it does or why we think it doesn't. Send us like something controversial and we can give our opinion on it, and we're going to have, I'm sorry, I know, I'm like just so excited. I'm remembering all the things that we talked about. David and I have coffee every couple of weeks and we have all these ideas. So we're also going to do like Ask Me Anything kind of shows, of which is what the email was actually intended for.
Right.
So you can send us the questions and then we'll have particular podcasts that we will designate and certainly notify our audience on of when we'll tackle those questions and just answer and give our opinion on what the answer is.
Right.
Yeah. And it's just our opinion, by the way. So take it or leave it.
So we are speaking, we're thinking of this podcast as for an audience of patients, families of patients, other healthcare givers, clinicians, physicians, parentheses, a bias. I hate the word providers,
Oh,
so I'll try to
sorry.
use the word
I
clinicians.
won't say that again.
No, that's okay.
No provider.
That would get us into
instead
a
of
whole new
providers?
topic. As far as I'm concerned, providers was invented by the managed care business to demean patient care. End of rant.
Okay. So what do you say instead of providers?
Clinician.
Clinician.
Oh, because I don't want to say just physician, because some of the
Right.
people
That's
are not.
why I thought. That's why I didn't say physician,
Right.
because
No, and
we
I know,
include
and I
other
still
people.
fall into the provider, but it gets me crazy. Anyhow,
Clinician.
what I was trying to say was,
But there are scientists that are not clinicians, but are really great scientists that we
but
both
they're not
know.
providers then. They are
That's a good point.
scientists.
Well, they're providers of scientific information.
Right, but the term is, the provider term is specifically related to healthcare and patient care. What I resent about it is the term is used, well, I don't want to get into labels, but I just think it's a bad term.
It's a managed care term,
Yes.
and which I am against as
Anyhow,
well. So I will no longer use
what I was
providers.
trying to get at is, in your feedback, let us know if we are, if our language is too medical, too sophisticated. Are we using jargon? Because to some degree, it's inevitable we'll use MCAS, and people might not know what it is. On the other hand, the goal here is not just to direct this to patients, but also to physicians. So, we're not, to use a not such a great term, we're not dumbing it down. We want to keep it at a level that works for everybody.
That's perfectly said. Perfectly said. The other caveat is, as I realized as you were talking, is that we are two New Yorkers
Right.
who happen to reside in Seattle. So if our accent is a little bit not pleasant to listen to, let us know that as well.
Well, the other thing, which I actually warn all my new patients when I meet my new patients, is I'm from New York, and you need to know I interrupt constantly. It's not that I'm being rude. I just interrupt. It's both the way I was brought up and it's the way my brain works.
That's right.
We interrupt each other all the time.
All the time.
I've actually tried
and we ramble
not
all
to
the
do
time.
that because this is also new.
I know.
How to do
We both keep hitting the microphone.
But I think once we're more comfortable, we'll be going
For
strong
sure.
and interrupting.
For sure. Yeah. So we ramble, we interrupt, we go off on rants. Sometimes we go on to a different tangent.
Right.
But we just want to share really good information. And that's actually what we think of this as, sort of information dissemination. And that's what we really want to do. And we want to speak to patients and patients' families and doctors and other healthcare clinicians. I'm trying not to say the word providers.
Right. I won't do it.
I'll get better at it. So we are excited to do this and to have you join us for this ride.
All right. Thank you very much. We look forward to working with you all and doing this again. It's very exciting for us.
Goodbye. Thanks for listening.